There have been several publications recently looking at the outcomes of ALL, stratified based on patients' ethnicity or income, the socioeconomic determinants of health. And what was reported or what was observed is that patients who are Hispanic and who are of Hispanic and African American ancestry have inferior survival outcomes, especially in the adolescent and young adult age group, meaning age 15 to 40 years old. And this data came from the National CA Registry data that is collected from patients treated at the United States. And then, interestingly, when we looked back and investigated outcomes in 10403, the standard of care that we use for AYA right now, and that particular trial outcomes. When patients participated in the trial and received the therapy, Hispanic patients had equally good outcomes compared to the white patients. So this raised the question that perhaps it's all about delivery of the care, and if you get the treatment to the patients, if patients can complete the treatment, then their outcomes might be better. In other words, perhaps the racial part here is a social construct rather than a biologic construct. That was the hypothesis to start with. And what we did was we looked at our real world outcomes, but University of Chicago outcomes. So we have a specialized adolescent young adult clinic here that we treat these patients. We also looked at our older adults, and we tried to investigate how socioeconomic factors and also non-biologic risk factors predict outcome in these patients when they receive care at a tertiary care center. And what we observed was essentially that the race, ethnicity did not predict outcomes. In other words, African Americans or Hispanics treated at the University of Chicago had similar outcomes compared to patients who are white. And also we did income-based stratification and analysis as well. And similarly, lower income patients treated at the University of Chicago had outcomes as good as high income patients. So obviously this speaks volumes about the ability to deliver the care, like social worker support or the resources that we can offer to make sure these patients can come, make sure they receive their treatment. And we also looked at several other variables, which can be biologic variables. And one thing that stood out was BMI, obesity. So whether in the national data or University of Chicago data or any other, in almost all data that we looked at, obesity was an independent predictor of poor outcomes. Patients with a BMI above 40 had worse outcomes everywhere. So that it seems like the obesity is a true biologic variable that we need to investigate further, how it modulates outcomes of ALL. But it's also encouraging that if we can improve the care delivery, we can overcome some of these socioeconomic based healthcare disparities.